Good morning. It is March 21st, 2023. I'm Dr. Duke Majan. We're broadcasting live from the Duke Spine Institute, Surgery Center, Viera. This is it, right here, Luis. Our first patient is having a 2-level cervical Duke laser disc repair shot. All right, not bad. Let's try pulling a little bit harder, guys, and just a little bit. Give me some inline shot. All right, not bad. 2, 3, 4, 5, 6, 7. Everyone agree? I agree, sir. All right, relax. So our patient has 3 disc herniations in their neck. And C4-5, C5-6, C6-7. We are fixing 2 of them today, Raytech. This patient has a very thick neck, broad shoulders. So it makes seeing the lower levels of the cervical spine challenging. We have to use some techniques where we pull the shoulders down. We pull hold the head stabilized, kind of pulling it, so that it pulls the shoulders and the skull apart just a little bit so the x-ray machine can see down to the C6-7. The C4-5 is not difficult to get to. You could see C4-5, Jordan. Let's show us the C4-5. That's correct. So count down from C2. Yes, 3, 4, 5. So the C4-5 disc is our other target, but the C6-7, which is down where we are, show us C6-7. That is the hardest one to get to, but we're in, and everything is looking good. Give me an AP. You don't have to pull the shoulder. So we're going to use a lateral view and an anterior posterior view to confirm that we are actually in the right place and that the dye has spread properly. And you're going to see an annular tear. Well, typically you would. Show them the annular tear in the back of the disc. Can you guys see it off to the left?
Yes, we can.
We're going to point it out to you. To the left. Other side. Keep going there. Just down a little bit. See that black line? Nope. Up. To the left. Down a little bit. There. See that black line right there? That is the annular tear. That's where the herniation got out. So that tear in the annulus is from trauma. Let's go ahead and show our audience, why do herniated discs cause neck pain? And how do they cause arm pain? Meanwhile, we're going to proceed with making our incision and getting our guide wire in place. There's no epi, right?
No epi, just a light.
Mm-hmm. Guys, this is going well so far for the patient. The other needle. So, you want to wait? Yeah, we'll wait. You're right. So let's just do this first. Go ahead and run the video showing why do herniated discs actually cause neck pain and arm symptoms. Meanwhile, I'm making a 4mm skin incision.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, Submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. We are now entering the C6-7 disc. This is where the largest herniation is, C6-7, off to the patient's left. It's huge. Good. All right, let me have the tube. Quickly, the tube. All right, we're going to do the entire surgery through this small 4mm tube. This is as minimally invasive as spine surgery can get. As you saw on the video, there's a tear in the back of this disc, shot, and that's where the herniation escaped from, a tear in the annulus called an annular tear, and specifically a posterior annular tear because it's in the back of the disc. So we call the back posterior. Anytime you're talking about shot, a body part, and if you're talking about posterior, you're talking about the back. All right, so you got to watch the tip, make sure the tip, see how the tip has come back? See, the dilator came all the way back. It was literally pushed from the herniation back in. Yeah, shot. So now I have to bring the tip of the dilator back to where it needs to be at the back of the disc. That happens because of pressure inside the disc. There it goes again. That's abnormal pressure. What's causing it is inflammation. Everyone has had inflammation before in their lifetime. Inflammation is swelling and increased blood flow. Shot? Shoot. This dilator just keeps coming out because of pressure. I could feel it. Shot? Can you see it, Henry? Watch, it just pops out. You see that?
Yes, we can.
It literally, watch this, guys. Take a look at the tip of the dilator. It's literally going to pop out. Can you see it on the camera? Eye in the sky? Eye in the sky.
Yes.
Okay, watch. Here it goes. I'm just going to let go of it, and then it popped up. You see that? Literally popping up, like a little bullet coming out. Shot? All right. You? Really? Luis? Yeah. You sweating bullets? Shot? All right, we got to make it to the back of this disc. And I don't want to biopsy the disc. So you got to keep the dilator in place. If you let the dilator go out of place, then essentially you're just biopsying the disc, and you don't want to take the normal disc from the center of the disc. You want to remove the herniation. All right, that should be good. We're back at the back of the disc. Show them, Jordan, where we are with the tip of the tube. Shot. All right, so you see how the tip of the tube with the arrow is at the back of the disc now at C6-7. Let's count the bones. 2, 3, 4, 5, 6, 7. So we are now in the C6-7 disc. Show them the endotracheal tube and the esophageal temperature probe. Endotracheal tube and esophageal temperature probe. Very good. So that's where your trachea and esophagus are. This patient is intubated under general endotracheal anesthesia, completely relaxed, thank you, Dr. Berndes, and sailing through the surgery. We were worried that we weren't going to be able to get to C6-7 because of the broadness of his shoulders. He's got the shoulders of a football player, and when people have big shoulders, sometimes we can't get down to the C6-7 level. We actually had to abort one of our DLDR surgeries a couple of weeks ago on a patient whose collarbone, right here, you guys see this?
Yes, we do.
Collarbone right here. Let me have the marker. So the collarbone is really what limits our ability to do the surgery. This is the collarbone right here, okay? And this is the top of the collarbone. The patient a few weeks ago, his C6-7 incision was down here, and we literally could not get the tube in place to get to it. That just shows you how much variation there is in the position of collarbones. And it's impossible to know where the collarbone will be during surgery because we put the patient under relaxation. So all their muscles are relaxed. You can move things around. But we just could not get the collarbone down far enough. All right. Let's show our video of how the Duke laser disc repair does its work. It's an annular debridement where we go in and clean out the inflammation from the annulus. We also remove herniated disc while we're in there. And The procedure's primary job is basically to treat the annular tear so that the tear will actually heal itself properly over time. I wonder if we're just having a little bleeding. What are we set at, 20?
20, yes, sir.
All right. So those are all pieces of disc herniation already. Yeah, I see that, thanks.
Thank you.
Let me grab that out. For some reason, I'm a little blurry. I don't know if it's some bleeding or if it's something with the scope. I need you to help me figure that out.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. We are proceeding here as planned. We're going to change the scope out because I'm not happy with the image that we're getting. Are you sure you checked this?
Yeah.
There's no way. I mean, that's...
You can
Open the scope. We're going to change our scope out and see if we can get a better picture. Light off. Come on, guys, got to pay attention what's happening. Nurses, whoever is in charge of scope. Why is the scope still on? I need that scope. There's something probably with the scope. Any questions from our audience?
No current questions.
So our patient presents to us with neck pain and arm pain, weakness, numbness, tingling, radiculopathy. What we're doing here is, in the cervical spine, a decompression of the nerve root and spinal cord and an annular debridement. Those are really the two main procedures that we'll be doing today. The annular debridement being the most important. The annular debridement is where we clean the tear where the herniation comes out of. We clean it with the laser, we debride it, we get rid of all the scar tissue, calcium, inflammatory tissue, herniated nucleus pulposus, basically all the stuff in there that's causing problems for the patient. All right. Let's see. That scope needs to be repaired. Okay? The light is too bright. We need to take the light intensity down.
You got it? Thank you.
Bring the light intensity down. There's a piece of herniation right there. I'm hoping it will just float up. Once again, we're starting with the C6-7 disc. We started with the more difficult disc to reach, and then and also I think the worst herniation. The laser fiber is at 12 o'clock position. It is the glass thing. What is the laser fiber? It's actually a glass tube that transmits laser energy that's created by the foot of the patient here by a machine called a holmium YAG laser. And the lasers we use at Duke Spine are all FDA approved, and everything we use at Duke Spine is FDA approved. Why is this liquid dripping on my feet? Fuck. There's a lot of confusion about lasers in spine, and basically lasers in spine do not work unless you actually have a holmium YAG laser or a type of laser that is used to ablate the bad tissue. There's a lot of people trying to sell patients on getting laser therapy through their skin. Laser therapy through the skin doesn't work. It may make you feel better for a little while because it produces heat and it causes vasodilatation, where you get your arteries and capillaries dilating. What's the issue here? What's the issue?
No issue.
And that increases blood circulation and blood flow to the area, but it only increases it to the muscles. It's not actually going to fix your disc herniation. The problem is that most people with back pain, 82%, 83%, have a herniated disc as the cause. And lasers applied to the skin will never fix that. They will never get rid of the symptoms either. The only way to get rid of the symptoms is going to be to do an annular debridement endoscopically, like you're seeing right now. There is no other way that works. Now look here, there's a tear right there. I want you to pay attention. Right there is a tear in what's called the posterior longitudinal ligament, which is the last ligament just above the spinal cord. So we're looking at a tear in the ligament in the back of the disc. Most disc herniations don't involve a ligament tear. They involve an annular tear. But behind the annulus is a ligament called the posterior longitudinal ligament. And in the case of this patient, there is a tear in the posterior longitudinal ligament as well. Most patients don't have a ligamentous tear. They just have an annular tear. And the herniation remains above the posterior ligament. But in this patient's case, the herniation is so bad that it's gone through the posterior longitudinal ligament. That's it right there as well. You see that? I'm literally breaking up the herniation that's sitting on top of his spinal cord with the laser. Now, people think lasers are dangerous, but they're not. They're actually, like any tool, it's dangerous in the wrong hands. But a trained surgeon who is trained to do laser surgery on the spine, has experience doing laser surgery on the spine or brain, that kind of a surgeon can actually use the laser's full potential. The laser is an incredibly precise tool, more precise than any other surgical instrument we have. And the reason for that is the energy is emitted from the tip of this laser 1/2 of a millimeter, 1/2 of a millimeter out. See the giant herniation right there in the epidural space? That's a nice one. That's a good one for our special pictures. There it goes. So keep this video in our special file, and you can see the herniation sitting on the spinal cord right here. I just took out a big chunk of it. We're going to get rid of some more of it in a second. And you can see how it's torn through the posterior ligament. Those are the fibers right there of the posterior longitudinal ligament. Now, if you're a spine surgeon and you want to get into this type of surgery, you can't just start doing it overnight. You're going to have to be trained. Here comes the herniation. Oh, it's big. Look at this thing. And it's sitting right on top of the spinal cord. So what I'm doing is I'm basically releasing that herniation by opening up the PLL, or posterior ligament. And by doing, oh, here it comes. Do you see that down there, just as we were leaving? You saw a
Yes, we did.
giant blue herniation. Wow, look at that thing. Oh, baby. Come on out. Okay? So what's the advantage of the Duke laser disc repair over traditional fusions or other types of surgery? Number one, you guys can see there's a 4 millimeter incision. It's tiny. So there's no incision-related issues, complications, like the wound not healing, okay? And then having to come back and have a revision, a wound revision. with a plastic surgeon. Second of all, we don't get the trouble swallowing with this surgery. See how I had to open the PLL fibers with the laser to get this herniation out? It's so big. I had to cut the PLL, posterior longitudinal ligament. The herniation is literally sitting on top of the spinal cord. Here it comes. And the laser is jiggling it out of position. So the laser is used to vaporize the PLL to release the herniation, but also the laser is jiggling it because it creates a pulse wave that shakes the herniation right out of where it is. All right, see how it's coming out in all those pieces? How many pieces have you counted so far for this herniation that's sitting on top of the spinal cord? How many pieces? I've counted at least 4. 4 pieces so far. And there's more down here still to come. Oh yeah, look at that thing jiggle. It wants to come out. We call this a reverse herniation, where the herniation reverses its direction and comes back into the disc. Oh yeah, there it is, big one. So do you see that piece of herniation? That happened with one event. There's the spinal cord, folks, right there. That is the spinal cord. It's stained a little bit blue because the dye went through the tear like I showed you earlier. Okay? That's the spinal cord right there. Okay? And there's a huge defect in the PLL where the herniation was. This is definitely one I want to keep for educating. Please. And just go ahead and get a couple of pictures, Henry, right here. Hold on. Let me just see if I can clean it up a little for you. Yeah, that's probably going to be as good as it gets right there. Go ahead and get a picture of that. Tell me when you're done so I can move on.
We're good.
All right. Again, I got to go through some more of the PLL. You see the herniation still there? See that? Giant herniation still there? This was a huge herniation. So I'm having to cut through the posterior ligament, but I've got the disc herniation between me and the spinal cord, so it's safe to do. But again, if you don't know what you're doing with this surgery, you're going to hurt somebody, which is why patients need to be very selective about who they, hire to do their surgery. You want the best. You can get the best at Duke Spine Institute. Most spine surgeons I wouldn't go to myself. I don't trust them. Look at how this herniation is squashing the spinal cord right there. That's really, really cool. So this is truly what's called a decompressive discectomy. In the medical CPT code world, this is a 63075, okay? A decompressive discectomy. Here it comes. Boom! Wow, was that awesome or what? Did you get that on video?
Yes, we did.
Save that segment. That's beautiful. There's a huge herniation. All right, so how many pieces have we counted? I've got at least 7 or 8 now. Really, really cool. Now this patient traveled from Delaware, right? Wasn't that the original state? The Mayflower? Have I got my history right? Yeah. So he's from Delaware, traveled to Florida, to Duke Spine Institute, to Orlando, and here he is today getting the most advanced disc surgery in the world for his spine, the Duke laser disc repair. All right, any questions? So we're having a lot of fun getting all these herniation pieces out.
Yes, we have a question from Danielle on YouTube.
Hi, Danielle.
And they said, I got L4-5 and L4, 2 herniated discs causing extreme pain.
Yeah.
I have DDD, spondylolisthesis, and some other stuff. Is radioactive ablation the same thing you perform with
No.
the laser?
No.
I was told this was my next step.
Yeah, you don't want radioactive ablation. That's radio frequency ablation, and it's not the same. Nobody else does this surgery. Duke Spine Institute pioneered it, and I've trained a few surgeons virtually, but you're going to want to come to Duke Spine to get this done. You're not going to find this where you are. Okay? And radio frequency ablation is to treat your facet joints, not your disc. Okay? So your doctors are mistreating you already. They're giving you the wrong treatment. And there's a reason for that. They make a lot of money doing those procedures that don't work, and it keeps the patients coming back for more. So it makes great business sense for them, but it's not good for you, the patient, because you want to be fixed. All right, so I have gotten about 90% of that herniation out. That thing is literally sitting on the spinal cord, and this is where you really need a surgeon who uses good judgment. You don't want to be chasing things that don't need to be chased. I get this question a lot from people. Is the herniation going to be completely gone? The answer is no. Your herniations are never going to be completely gone. The goal of surgery is not to remove 100% of your herniation. The goal of surgery is to make you symptom free, meaning you don't have any neurological symptoms and you don't have any pain. All right, that's our goal. It's not to make your MRI look normal. If the goal of surgery is to make an MRI look normal, no surgeon would operate, because you can't make an MRI look normal, not with surgery. Only God can make your MRI look normal. We're not gods, we're just people. We don't have that ability. So my goal with surgery with every patient is to get rid of their neck pain, get rid of their arm symptoms, get rid of their spinal cord compression symptoms, myelopathy, and give them normal functional status as is humanly possible. All right, this is embedded in the spinal cord. This is far worse here that I'm looking at. It's worse than his MRI showed. His MRI didn't show it this bad, so he's clearly progressed. Okay, there's PLL. I'm cutting the PLL, and this stuff is all in the epidural space. Once you go past the PLL right here, you are literally in the epidural space, and there's a huge herniation. I mean, we've taken out so much, and look at the calcium. So he literally shot this thing out. We're getting out into the foramen. Here comes a piece. You see it? See it wiggling right there? Peeling it off the spinal cord. Peeling it off the spinal cord. This is the most delicate surgery you can do in spine surgery. And the laser, look at it. It's beautiful. It literally peels 1/2 of a millimeter. 1/2 of a millimeter. A millimeter is the smallest space you can see between your fingertips if you close them. This thing is peeling 1/2 of a millimeter. And it looks huge to you and I because we're looking endoscopically. There's some inflammatory tissue. We're looking endoscopically, folks. And the endoscope magnifies this view. It makes it big. It looks big. Okay, get this. You see the sides of this tube? They're literally 2.5 millimeters apart. That's tiny. So just to give you an idea of how precise the laser is, you see that laser fiber down there? That laser fiber is 1/2 of a millimeter, right? Luis, 1/2 a millimeter wide?
Yes.
So that just gives you an idea of how precise this laser really, really is. It's far more precise, far safer than any other type of surgery. The people who bash laser spine surgery, and all laser spine surgery, don't get me wrong. I'm supporting one laser spine surgery. It's called the Duke Laser Disc Repair. It's what you're watching now. This is the very best of the best. Man, that thing is still pushing there. So your surgeon that you go to, pick any spine surgeon in the world, they cannot do this. This is literally maybe 2 or 3 surgeons in the world can do this surgery. Me being one of them at Duke Spine. Okay? So it's not bragging, it's all those other surgeries, artificial discs, sure. You know, I've done thousands of them. But this surgery can only be done by a handful of the best surgeons in the world. And that's what you guys are watching right now. Okay? You're not going to find this anywhere else. I learned the basics of cervical endoscopic surgery from the Koreans. But in the United States, all the doctors are doing fusions. But this is far better than a fusion. Now this herniation is in the foramen. You guys can see the spinal cord. The spinal cord is right here, okay? And it wraps around and it becomes the nerve root which runs out the foramen. And all this stuff is pushing on his nerve. And so I've got to get rid of this herniation in the neural foramen. That's where we are, the neural foramen. Look at that, that wants to come out. Okay? Very delicate work. Remember, that laser fiber is 1/2 of a millimeter wide. So you know how precise this really is. I mean, it is massively precise. But look at the decompression we've already gotten. Yep, this is his left foramen at C6-7. Left C6-7. And his surgery is going really, really well. All right, let's see what we got left in here. Got a little bit of herniation here still. I'm just blasting it away, just trying to be as careful as I can. I'm not making any sudden big movements. Everything is very small. This is this is why neurosurgeons do this surgery. By the way, the ligament there I just took down was foraminal ligament. It's an extension of what's called ligamentum flavum. Ligamentum flavum, a lot of surgeons don't know this. It wraps around from where the lamina is in the back of the spine, and it wraps around and goes into the neuroforamen. Look at this herniation here. Just taking it away piece by piece, bit by bit, just whittling it down. But look at all the golden color. That's all calcium. That's all calcium. That means it's been there a long time, pushing on this nerve. A long time. And this is the stuff that surgeons cannot get out. Okay, when you talk about an ACDF, oh, look at the herniation just pop out. You guys see that? How cool is that? Oh, I love it. Success. That's it, man. We are just about done with this disc. I'm going to go look at the other side one more time. But we just decompressed the nerve root. It's incredible. This is beautiful. So you got look at the nerve root right here. That is the nerve root right there. That's the nerve root. The C7 nerve root. How cool is that? Get a picture of that. Can you do that? Henry, just say, I got it, got it. Take a bunch of pictures.
Got it, got it.
Yeah. Look at the nerve root. That's the dura, or covering of the nerve root right there. And we just took all that pressure off. There's still a little bit at the shoulder. This is more, I just want to make sure I get as much as I can. This is not going to be causing any symptoms. Look at how much better of a surgery this is than anything else. If you've watched ACDFs, you'll know. If you're a surgeon, you know. The problem is surgeons don't know how to do this surgery, okay? You can actually see the full nerve root. There's the top edge of the nerve root right there. I've gotten all the pressure off of it. Berndes, you doing all right?
Yeah, I'm just watching.
Pretty incredible, huh? I've not seen such good anatomy. I mean, this is incredible. That's a left C6-7 foramen. That's the C7 nerve root on the left side. And, huh? That's impressive, huh? Now I'm going to go back and look across, make sure we don't leave any herniation in the middle. Oh, this is the future of spine surgery today. That's right. All right, what other questions? Any questions? We're done.
No current questions, but we do have a comment from Canes25 on YouTube.
Yep.
They said, this
Hi,
case
Haynes.
this case really complicates your technique and shows technically what a tactician you are.
Thank you very much, Haynes. Yeah, I mean, the truth is that any spine surgeon that really cares and wants to learn and wants to do the very best for their patients and have the best surgical treatment, they can learn this, you know. There's nothing magical about me. I'm just a guy who just really pays attention to the details and loves anatomy and loves pathology and fixing it, you know. And it just, you have to find the right person to be your doctor, to fix your problems. And we broadcast this because unfortunately there's a lot of bad surgery being done. A lot. About 90% of spine surgery in the United States is bad surgery, in my opinion. Probably more than 90. I'm just being generous, conservative. No. So here's the deal. This patient has 3 herniations, okay? Number 4, 5, 5, 6, 6, 7. We just did the hardest one. I always start with and because we're only doing number 4, 5, and 6, 7, we're skipping the 5, 6 per patient request. I'm going to take this out, and we're going to go ahead and do a second needle higher up. Okay? Right? Just take it out. We don't need it. Normally, if we're doing 3 in a row, we would move the whole contraption down or up to get the other discs. That's the Duke spine maneuver. I can call it the Duke spine maneuver because nobody else in the world does it, and I'm the one who pioneered it 16 years ago. Never really thought much about it, to be honest, about the multiple disc treatment, but I've actually heard online and from some people who, go to Korea, they do one disc. They won't do 3, they won't do 2, they won't do 4, they'll do 1. And they don't know how to move from one to the second one. That's why they only do 1. But here's the problem. The average patient has 2.5 discs that need to be fixed. So if you've got 2.5 discs that need to be fixed, and your surgeon can only do 1, and there's only 5 surgeons in the world that do this, endoscopic cervical surgery, and only one of them does multiple discs, well then that makes me the only one in the world doing multiple cervical discs endoscopically during a single surgery. So I started doing them 16 years ago. I never even thought much about it, I just did it. And have been doing it since, and it works great. All right, nice thing is I can feel his spine nicely with my fingertips. Shot. All right, so 2, 3, 4, 5. That's our next level is number 4, 5. It needs to go up with just a little bit. Shot. All right, I'm right over the 4, 5 disc. Huh? What is it?
No,
Yeah, it could be a little bit more north. The neck is supple, which is really nice. It makes my job easier. Shot. All right, so that looks good to me. Let's get an AP and make sure we're in the middle. You guys are witnessing the technique right now. Normally, sometimes we start the live stream after I've already started, but you guys are witnessing the technique. All right, lateral. So I'm right over the middle there, which is perfect at 4, 5. So I'm going to enter the 4, 5 disc through the front. I'm going to go transdiscal. Okay, you guys see that? Shot. Luis, you agree?
I agree, sir. Yeah.
Man, that disc is collapsed. Shot. Let's get an AP. Shot. Let's just make sure we're in the middle. Huh? Yeah, I want to make sure I'm midline. I think I am. 2, 3, 4, 5. So it looks good on the lateral view. Actually, the AP view looks good too. I'm just encountering some bone spurs in the front of the disc, which, huh? Oh yeah. Oh, that I felt it. It went in. Yeah, that helped. That helped. Thank you. I felt it go. Yeah, not all the way, but it did start going. A little more. Oh yeah. Shot. Okay, almost done. Oh. So I'm placing the spinal needle first. Shot. I'm in. That's beautiful. Nice work. Yeah, you did a chiropractic treatment. We don't even charge for that. So can you guys see here? Because we're doing 2 discs and they're separated by a disc that we're not doing treatment on, you're going to have the Dracula effect. That's when Dr. Duke gets really hungry and I haven't had breakfast. I make 2 little puncture marks and I feed. Okay. All right. Here's our special die. We're going to do a discogram. Shot. All right. You can see the tear. It's a pretty crappy looking disc. Shot. Yeah. Show us the tear in the back. There it is. Okay. Very good. All right. Guide wire. Any questions?
No current question. Oh, we have a couple
Shot.
comments and a question.
Excellent.
The first 2 comments. For first one comes from SPX 730 on YouTube. And they said, "This is one of the most exciting I've seen. Amazing shots."
Oh, thank you. Yeah, I agree. I totally agree. It's not often we get such clear views of the nerves and spinal cord. And you know why? As I pointed out earlier, most herniations do not penetrate deeper to the PLL, posterior longitudinal ligament. They're superficial. Therefore, we don't go past the PLL. We leave the PLL intact. You don't want to go past the PLL if you don't have to. That is where the spinal cord is. That's where, things can get ugly if you don't know what you're doing. Of course, we know what we're doing. but you don't penetrate the PLL to treat a disc herniation unless the disc herniation penetrates the PLL. Shot? And if it penetrates the PLL, then the disc herniation is going to be touching and pressing on the spinal cord. And that's what happened with his herniation. It was so large that it tore through not just the annulus, but also the PLL, posterior longitudinal ligament, in the back of the disc, and was squashing the spinal cord and nerve. So because of that, which is not a common finding, maybe 5% of surgeries, you see that in the neck, but because of that, that's why we had to take down the PLL to expose the herniation sitting on top of the spinal cord. So yes, it is a really, really cool surgery, which is why I have Henry saving it for me so I can go back and look at it later. It's kind of like watching your kids on video, you know, as they grow up. You take pictures of them and videos, you go back and look at the family picture book. I like to go back and look at the herniation picture book. All right, in all seriousness. All right, so beautiful on the lateral. I'm really stuck at the front of the disc. You can see bone spurs and stuff. So let's get an AP and just see where we are, make sure we're in the midline. If you're doing these surgeries in your career, if you've learned how to do them from me, you need to make sure you check both AP and lateral views frequently to make sure that you are in the midline. There it is. Show us the midline. You can see the spinous processes, and the tip of the dilator is exactly in the midline. Show us. There's the tip. Yep. The guide wire itself goes across the disc to the back, and it's supposed to. Great news. Duke Spine Institute has just purchased 2 brand new top-of-the-line Siemens intraoperative fluoroscopic units, the best in the world. And we're going to be rolling those out next week for our cases. And we have the best fluoros, Siemens fluoros, flat panels. And these are the newest model that came out recently, and we're buying 2 of them for our patients. So why is it important? Ready?
Good.
Yeah.
You want a little shoulder?
Yes. Yeah.
Shoulder pull?
Little shoulder, little shoulder. Shot. We're going to do a little distraction. That's me right there.
Yes, sir.
I'm going to make you guys aware. Oh, yeah, look at that distraction. That's nice. Shot. Yeah, you got good. You guys pulled it apart about 1 millimeter, maybe 1.5 millimeters. Almost there. Shot. All right, good. We're at the back of the disc. So why is it important? I'm going to tell you guys a secret about fluoroscopy units. Fluoroscopy units are X-ray machines. They produce X-rays, and then they detect the X-rays. So they produce and detect the X-rays, and they pass the X-rays between a space between the emitter or producer and the detector, okay? And the newest technology in fluoros are flat panels, and they've been around for 10 years. Maybe a little longer or shorter, but about 10 years. Flat panel technology replaced the old detector technology, which was not nearly even close to as good. So when they came out with the flat panels, we invested, and the problem is these machines are $160,000 each. So they're a huge financial investment. Duke Spine Institute, we're a mom and pop shop right now in the year 2023. We have one little building, 20,000 square feet, and you know, we don't have venture capital money. We don't have investors. We just pay for everything ourselves, and we don't have a lot of money to do that. We're near some of the most wealthiest hospital systems in the world. For example, Advent Health is in Orlando. They make $10 billion a year. So buying a fluoro unit is not a problem. Let's give a little distraction, guys.
Ready?
Yeah, I've been hoping you guys were doing it.
Yeah.
Ready, go. And then, of course, Orlando Health is their competition. These 2 hospitals together make around $20 billion a year in revenue. Duke Spine Institute is a tiny little company. We're not here to compete against the hospitals. We just want to provide the best care in the world for spine. So a little company like ours, you know, buying something for $150,000 or $300,000 for 2 of them is a big expense. And it hurts and it affects everybody's bottom line, but it's a worthy investment, and it's an investment in quality. The problem, folks, is that if Duke Spine struggles to pay for a $150,000 X-ray machine, you can imagine what other doctors are doing. They're not spending $150,000. They're buying the cheaper used machines. And the cheap machines and the used machines, well, they have something in common. And that is that the quality of the pictures are horrible. And if your quality of your picture is horrible, how can you pound in a tube over the spinal cord if you can't see it, right? And that's exactly what they do. They do procedures without really being able to see what they're doing. And guess who suffers if they make a mistake because the x-ray machine is of poor quality? The patient. And then of course the doctor comes out and says everything went well, but I'm sorry you didn't get any better. You know, we did our best. Well, what they're really saying is we're a bunch of cheap asses who don't want to spend money on you and want to just say we did the procedure so we can bill for it. Now, it may come as a surprise that just because Duke Spine buys the very best equipment for our patients, we actually don't get reimbursed anymore for that. We get the same payment the other doctors do. So it makes sense then that if you're really focused on just making money, you're going to go with the cheapest machine because we all get paid the same amount. And you don't get rewarded for investing in quality. And that's the problem with healthcare today, is there's no reward to the providers for having higher quality. You don't get reimbursed more money. I'm only bringing this up because nobody's asking questions and because I like teaching you guys the truth about healthcare, because nobody else is going to teach you the truth about healthcare but me. And maybe there's a few other doctors out there, but they're not broadcasting their surgeries every week. But we are. So the truth is that the quality matters. The outcomes are determined by the quality of the equipment, the drugs, the anesthesiologist, the surgeon, and there's a lot of bad surgery being done. And what I mean by that is there's a lot of bad equipment, a lot of bad medication, a lot of bad surgeons and their techniques, a lot of bad implants being used. There's just a lot of bad all around. Now you might think, hey, why don't you standardize everything? Well, good luck with that. You're not going to get all the doctors to do everything the same way. But that's what I want to do. I want to standardize. Okay? I believe that the treatment of spine problems should be standardized because there is the best way to do it, and people should either do the best way or they shouldn't be doing it all. That's my opinion. And the reason I have that opinion is because ultimately I'm a patient advocate. I want the best for the patient. And if the patient is not going to get the best, that's not fair to the patient, especially if they think they're getting the best because their doctor told them they're getting the best when they're really not. By the way, that's a bone spur I'm taking down right there and a herniation. Bam. You guys see the herniation come out?
Yes, we did.
Nice. Any questions?
Yes, we have two questions, both from SPX730 on YouTube.
All right.
First question is, how do you make sure you don't poke an artery, doctor?
Well, SPX, great question. The way I don't poke an artery is you got to know where the arteries are, and you got to avoid them. So that's what I do. The whole reason that I use the technique you just saw a minute ago is because that technique avoids the arteries. In other words, if you were going to travel through the jungle and you knew you had to get from point A to point B, but you knew there were lions living in a certain part of the jungle in a valley, you're going to avoid that valley because you don't want to get involved with those lions, okay? Same thing with surgery. We surgeons learn the anatomy of the human body. We know where everything is. At least you're supposed to, at least. The good ones do. The bad ones, not so much. And we know how to avoid the arteries. The second thing is arteries are pretty firm. They're not as flimsy as you would think. Veins are very flimsy, but arteries are tougher. They roll away from, surgeons. They basically move away from us because they have a very thick muscular wall. That's what separates arteries from veins, is the tunica media, which is the wall of the blood vessel. And arteries have a thick muscular wall, and it's really hard to poke an artery, to be honest with you. Right, Dr. Berndes? Berndes?
Yeah, well, different
Yeah. A vein and an artery are completely different kinds of tissue. This is a really messed up disc. As compared to the other one that was more of a, I don't know, there were parts of it that were older, true, but there were some parts that were newer. This is an older herniation. This is all scar tissue here. Tons of scar tissue. And I'm not really trying to get rid of scar tissue. I do want to get rid of some of it because it can be problematic. But my goal is to get rid of herniation.
We have another question.
Sure.
This comes from SPX 730, once more on YouTube.
Uh-huh.
And they ask, could you probably lease such medical equipment rather than just flat out purchasing them?
Well, leasing is more expensive than purchasing. I don't know if you know that. But when you lease medical equipment, then you're building in financing costs. So you have to pay not just for the price of the equipment, but you got to pay to finance it. So some banker is making money off of you, maybe 6%, 7%. Well, 6 and 7% doesn't seem like a lot of money, but when you're talking about $300,000, that's going to be, what is 3 times 6? 18. You're looking at least $18,000 more in costs when you lease. So I'm not looking to raise my costs, I'm looking to lower my costs. You know, you still get to depreciate the asset from an actuarial accounting standpoint, tax standpoint. You get to depreciate the asset the same way. So from a tax standpoint, you're not really gaining an advantage leasing, in my opinion. You're just spreading out the costs over time, but you're paying more money for that. And that's if you lease it for 3 years. It's 6%. I mean, 6% a year. So that's, you could end up leasing for 6 years, 10 years, and then you're looking at paying a lot more money. You know, almost 60%, right? 10 years? Huh? Oh, yeah. 10 minutes left. Almost done. A lot of inflammation down there. You guys see it? The red stuff down there?
Yes, we do.
So that's why we buy the equipment, because it's cheaper to do it that way. I know it seems more expensive. Duke Spine does not have debt. In other words, the owners, myself and my wife and my kids, we don't believe debt's good. We think debt's bad. We're not. The problem in America with corporations today is that they all borrow money so they can pay themselves money as salaries and bonuses. We don't do that. We put the money back into the company. We want it to go into our equipment, our staff. We're not trying to exploit a company here like everybody else does. So many corporations borrow. They get themselves into trouble. They can't afford the debt service, borrowing. They can't afford it, and then they go out of business. We don't want to go out of business. We believe what we're doing here is helpful to people, and we want to continue to be here for years. And we want to be helping people get out of pain for years. So we value our company and what it does for society. So we're not going to jeopardize our company by borrowing money to pay ourselves big bonuses. We don't do that. I actually took a pay cut so that I could stay in business. I took a pay cut a few years ago during COVID, and I haven't given myself the payment back, the money back. And I'm okay with that, because for me, I enjoy coming to work every day and helping people get out of pain. All right, other questions?
No current questions. There's a comment from SPX 730 saying, it's good to not have debt, sleeping well at night.
Yeah, right? Exactly. That's the truth. Thank you for understanding. I do sleep a lot better at night. I really do, not having debt. When I graduated from neurosurgery training, I had $250,000 in debt because of medical school. I owed that much money just for 3 years of med school. I did 4 years, but my 4th year, I got a scholarship for my being number 1 in my class at USC and teaching neuroanatomy. So anyway, I came out with around $180,000 in debt. And of course I did deferment where I put off the debt because I didn't have any money to pay it back. And I did that for residency, you know, while I was a neurosurgery resident for 7 years. So I deferred my debt from medical school, $180,000 for 7 years. And then by the time I got done with residency, I went out and started making, you know, real money. Not great money, but good money. The first thing we did was pay off my debt. First thing we did was pay off that debt. And I paid off my wife's debt too. She went to PA school, physician assistant school, and between the two of us, we paid off our debt. And then we borrowed money to build an office, and as soon as we made enough money, we paid that off. So we've always big believers in, from a business standpoint, in paying off your debt ASAP. Now, of course, the banks don't want you to pay off the debt, right? They want you to keep the debt. Because they want to, you know, make interest money off of you. But if you're going to borrow money, my advice is always try to borrow with a no prepayment penalty. It's called no prepayment penalty. Nowadays, they penalize you for that. They give you a higher rate, but that way you can pay it back quickly. You don't have to pay it off over 10 years, you know, which they want you to do, so they can make more interest off of you. So anyway, there's no questions. We're just about done. If you have questions, type them up. Again, this disc herniation was different, and this one was mostly scar tissue and very little herniation actually here. So I think we just did a good debridement. There's a lot of calcium here, and probably need just another minute or two. You can see the PLL there. A lot of scar tissue. A lot of scar tissue. The scar tissue indicates chronic inflammation. All right.
Lights on, please.
I don't see much herniation there. Okay, great questions. And if you have more questions, feel free to type them up. But we've just done a cervical Duke laser disc repair for 2 herniated and degenerated discs in this patient's neck. The bottom disc, C6-C7, was really the herniation, and the top disc was more degenerated. The bottom disc was also degenerated, but not as bad as the C4-C5. So we fixed the degenerated and herniated discs. The bottom one was a lot more exciting, a lot more fun, great anatomy, great, you know, lessons to see, the nerve root, the spinal cord, the herniation sitting on top of the spinal cord. That was kind of fun. But we're done. And this patient, for those of you who don't know, this is an outpatient surgery. They're going home in an hour. In his case, of course, since he's from out of state and he's been bitten by Dracula, he's going to go home in tomorrow. So he'll go to the hotel tonight, and then he'll go home tomorrow, fly back to Delaware. I'm just removing our tube, and in just a moment I'll show you the incisions that we made on his neck. Now, because we're doing 2 separate discs that are separated by a disc in between them, we didn't do 1 incision, we did 2. But you'll see in just a moment that that incision is tiny, 4 millimeter. Let's show them the tube and the ruler. Take a look here. For those of you who want to know, the whole surgery was done through this tiny little tube. You guys see this?
Yes, we do.
Here's a ruler. Here's the tube. Take a look at that. You guys see the size of this tube? It's 4 millimeters.
Yes, we do.
Just to give you an idea of how tiny it is.
Thank you, sir.
So the problem is 99% of spine surgeons were never taught how to do the surgery. And to be honest, they're not interested because they make so much money doing fusions.
Thank you.
We've got to change that, folks. We've got to stop rewarding surgeons for doing more invasive surgery. Right? And surgery that doesn't work. And surgery that requires more surgery. Surgery that requires more pain management treatments for the same problem the surgery was supposed to fix. And more complications and more expense. My estimate is that if this country spends $100 billion a year on spine care, whether it's pills, shots, therapy, chiropractor, surgery, that we could eliminate literally 60 billion and be left with 40 billion worth of Duke laser disc repair and Duke plasma rhizotomy, and that would take care of all the degenerative spine care needed. 2 procedures.
Number one cause of out of work, of missed days of work.
Is that right? Back pain, neck pain? Interesting. All right, let's see what we got. So there was a little venous bleeding. We held pressure. There's still a little bit. We'll hold a little pressure. And, huh?
No epi was used. You might get a little more skin bleeding, but
Yeah.
fantastic blood pressure, mean arterial pressure.
But you guys see what I mean by the vampire got to him, right? So we're going to hold pressure for just another minute, a couple of minutes, and then we're going to put some steri strips on. A Band-Aid, basically. There's no suturing. There's no wound to close. It's literally a piece of tape on the skin, and that's it. Good job, everybody. Let's go ahead and show the audience one more time what is the Duke Laser Disc Repair Cervical and how it works. And then I'll come take your questions.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.dukespine.com.
Good morning, I'm Dr. Duke Majan. It's December 9th, 2022, and I have with me one of my patients who traveled from out of state, Texas to be exact.
Yes, sir.
And he is suffering with neck pain, and I'll let him tell you a little bit more about his symptoms, but he had herniated discs in his neck along with degenerated disc. We just repaired those yesterday, less than about 12 hours ago.
Yes,
as a matter
sir.
of fact.
Yes, doc. Yeah.
You're here now on post-op day 1. It was outpatient, no hospitalization. You stayed at the hotel. You're back this morning, and how do you feel?
I feel great, doc. You know, I just want to thank you right off the bat for you and your team for basically giving me another lease on life. I mean, the back of my neck, the tops of my shoulders. I had pain all the way down the back of my arm, and my elbow, and then also I had no.
Good morning, I'm Dr. Duke Majan. It's December 9th, 2022, and I have with me one of my patients who traveled from out of state, Texas to be exact.
Yes, sir.
And he is suffering with neck pain, and I'll let him tell you a little bit more about his symptoms, but he had herniated discs in his neck along with degenerated disc. We just repaired those yesterday, less than about 12 hours ago.
Yes,
as a matter
sir.
of fact.
Yes, doc. Yeah.
You're here now on post-op day 1. It was outpatient, no hospitalization. You stayed at the hotel. You're back this morning, and how do you feel?
I feel great, doc. You know, I just want to thank you right off the bat for you and your team for basically giving me another lease on life. I mean, the back of my neck, the tops of my shoulders. I had pain all the way down the back of my arm, and my elbow, and then also I had no grip. And today, it's all back. I just, you know, it's just a game changer. His procedures, because I've had fusions in the past, like 15 years ago, and those fusions, you don't want to do those because they just give you adjacent disc disease, and I have that problem right now on my back, and Dr. Dukes is going to fix it next week. So I'm very looking forward to doing that.
We'll be seeing him again next week after his back is fixed. But you broke it up into 2 procedures, and we get people all the time asking us, oh, can I come there and get my neck and my back fixed? Yes, you can. We'll probably do it on separate days. So you got 3 discs repaired yesterday. You can
Yes, sir.
actually see right here in this video footage how small the incision is, tiny. And I was in there endoscopically using a laser to clean out the tear and remove the small herniations. And now here we sent you home an hour after your surgery, and here you are back today. And how much of that pain did we get rid of?
All of it, Doc.
100%.
I mean, 100%. And I mean, doctor did. They did surgery on 3 different levels, and through a really small hole.
4 millimeters.
Yes,
4
Doc.
millimeters. Incredible.
And there's no stitches. It's just a Band-Aid.
Yeah.
You know, that's crazy. You know, if you have a fusion for three level fusion, I don't know how long that would be, but it's
It's
terrible.
about that long
Yeah.
for a 3-level fusion. And then of course you'll have swallowing trouble for months.
Not
And
good.
then you'll have pain and you'll be on narcotics. Are you on any opioids or narcotics?
No, Doc. Last night I went home and to the hotel, and I just took a Tylenol PM, and that's all the medication I've taken since the surgery.
Yeah. So with the Duke laser disc repair, you don't have to worry about getting addicted to painkillers because there are no painkillers. Literally a Tylenol, and that's it, because it's so minimally invasive. Far better than ACDF, far better than any other cervical type of surgery. Well, is there anything else you want to tell your fans out this up?
Yeah, I just want to let my parents know, and my 10 younger brothers and sisters, if you're watching this, if you have back issues, you need to come see Dr. Duke, because he is one of the only people in the world that can do this procedure, and it is a game changer, and it's well worth it. At least give him a review. He'll do a free MRI review for you. It's just do your research. Go to his dukespine.com, look at his website, and just do your research and give yourself a chance to do the right thing.
Well, thank you. And yes, now I'm the only one, but someday there will be another one
You hope.
who will be doing these
Yeah.
surgeries,
Yeah.
and probably better than me.
Okay, thanks, Doc. Appreciate
Thank
your
you,
help.
sir.
Yeah.
We'll see you soon.
Yeah.
Video insulin.
Okay.
Hi, I'm Dr. Duke Machen, and we've just completed our 2-level cervical Duke laser disc repair.
Yeah, there we go.
C4-5 and C6-7.
Awesome.
And as you can tell from the 2 small 4 millimeter incisions where the surgery was done, it looks like the patient came to Florida and was attacked by a vampire. But that's not the case, I assure you. He was attacked by a neurosurgeon. Overall, the surgery was successful. I'm very pleased with the results. The C6-7 disc, the first one I treated, we got in there, we saw a lot of herniated fragments. We saw both old herniation and new. The newer herniation is more blue, more fluffy. The older herniation was more scarred and calcified with the orange and yellow stuff. A lot firmer, a lot harder for the laser to get out. But eventually we had to unzip and open up the posterior longitudinal ligament, which was the ligament in the back of the disc just behind the annulus. That was also torn, and the herniation went through that, was sitting on top of the spinal cord. And so if you were to visualize it using a model, all right, the yellow thing here is the spinal cord, and this is the disc. You guys see how the herniation is pushing on the spinal cord there?
It's a little blurry. It's back
let's see.
now. Yeah, we almost had it.
Alright, there we go.
Yeah, there we go. There
All
we
right.
go. Yes.
So the herniation, this little red bump here, is pushing on the yellow thing, the spinal cord, and I had to go in and basically remove it from pushing on the spinal cord. Sorry about that, it's too blurry. But anyway.
Nah, it wasn't that blurry.
Well, we'll take any questions you all have.
No current questions, but we do have a comment, and there we go.
Any good? Did that work?
It's getting there. Calibrated. I think this calls for.
We may need a different camera.
There we go. Now we're perfect. No current questions, but we do have a comment from Jason on Facebook, who just says, "What a great share in surgery and life/business." And he's also just added, "I need the same surgery."
All right, well, we can do it for you, Jason. We're here at Duke Spine near Orlando, Florida. And we've done now 1,600 of these endoscopic surgeries over 16 years I've been doing them. And they're the best, honestly. The sad thing is that other surgeons don't pick it up. They don't know how to do it, so it's very limited for people to be able to get it done. They have to come here, which we're happy to treat you and take care of you. But you know, someday this will be the mainstay of treatment around the world for herniated discs, whether it's cervical, thoracic, or lumbar, because the surgery works for all three, and it's honestly the best results. Well, I hope you enjoyed our broadcast, and we only had one surgery today, so there's room for you on the operative schedule. We'll be back on Thursday. We have a few Duke plasma rhizotomies, and just to show you what is a Duke plasma rhizotomy, that's where we're treating a different kind of pain that comes from a joint called the facet joints, rather than the disc. Now the disc, and we have our research fellow who's doing a study now looking at thousands of our patients to determine what is the source of the pain. Hello, research fellow.
Hello.
That's Arias.
World.
Yes, hello world. He's going to Princeton, and he's doing a study or analysis of what are the causes of back and neck pain, and what percentage do they account for in terms of the incidence or prevalence in our population of patients here in Florida that we see, which actually comes from all over the world. And it turns out that the facet joints are around 10%, right, Arias? And that the disc is around 83%.
Yep.
And then, of course, that makes 93%. So other causes include the piriformis muscles, the sacroiliac joint, fractures, coccydynia. And we're going to be publishing these results in a journal probably in the next 3 to 4 months, hopefully. And then we'll have real numbers about the incidence of causes of back and neck pain. Any questions?
That is it.
Have a wonderful day. Thanks for joining us at Duke Spine Institute. And if you know somebody suffering with back or neck pain, feel free to use our free MRI review. That's mri.dukespine.com. Have a nice day. We'll see you Thursday.